Welcome to the April 2025 educational event. I'm Kavya Velagapudi, Executive Director of the Neuroendocrine Cancer Foundation.
I'm Lisa Yen, Director of Programs and Outreach.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach.
Today's presentation is on evolving management of carcinoid heart disease, what we know and what's new. A special thank you to our supporters, Novartis, Tercera, Ipsen, Exelixis, Curium, Cronetics, ITM, Boehringer Ingelheim, and InterScience Institute. We're pleased to share that LACNITS is now the Neuroendocrine Cancer Foundation. This rebranding signifies the strides we have made in reaching more patients and caregivers, and also in offering more educational and support programs. You will see our new branding being rolled out on our website, social media, and all communications. We appreciate your patience during this transition. Our team remains the same. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder, Giovanna Joyce Mbezi, and NET patient Mary Dunleavy. Neuroendocrine Cancer Foundation will continue to collaborate with the Carcinoid Cancer Foundation to provide its programs, including the Luncheon with the Experts and support line. Now I'll hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 400 educational wellness videos, testimonials, and podcasts. Click videos or playlists to find patient and caregiver stories, information on types of treatments such as PRRT, liver-directed therapies, and targeted systemic therapies. There is information on imaging, nutrition, and our annual conferences. And you can also find our educational videos by topic in our video library on the homepage. As we transition from LACNITS to Neuroendocrine Cancer Foundation, you can still find us on social media, Facebook, X, and Instagram with our new handle at NCF Cancer. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that our webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are from the experts' experiences and insights. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back over to Lisa.
Thank you, Heather. I've been supporting my husband, who was diagnosed with neuroendocrine cancer in 2015, and together we aim to stay informed and engaged with clinical trials as possible treatment options throughout our 10-year journey. We understand that one of the challenges is finding and understanding clinical trials that are right for us. And that's why we at the Neuroendocrine Cancer Foundation created a clinical trials guide that is easy to use and an educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as GI, pancreas, lung, or the types of treatments. And when you browse the site, you can find brief patient-friendly videos and information about each trial. We hope our clinical trials guide can help you better understand clinical trials that might be available for you. I'm pleased to introduce our speaker for today, Dr. Prashanth Venkatesh. Dr. Venkatesh is a cardiologist and an adult congenital heart disease specialist at the Smidt Heart Institute at Cedars-Sinai Medical Center in Los Angeles, California. He is an assistant professor of cardiology at Cedars-Sinai and also an assistant professor of medicine at the David Geffen School of Medicine at the University of California, Los Angeles. At Cedars-Sinai, he is part of the multidisciplinary neuroendocrine clinic where he cares for patients with carcinoid heart disease. Additionally, Dr. Venkatesh is a specialist adult congenital cardiologist at the Guerin Congenital Heart Program at Cedars-Sinai and also a member of the echocardiography faculty. He leverages his clinical expertise in these subspecialties to improve care for his patients with carcinoid heart disease. Dr. Venkatesh also is actively involved in clinical research and has authored several first author publications and book chapters. His research interests include echocardiography and adult congenital heart disease, in addition to outcomes and quality improvement in the contemporary care of carcinoid heart disease. I met Dr. Venkatesh through his involvement in the Cedars-Sinai Multidisciplinary Neuroendocrine Clinic and have been impressed by his active role in the care of neuroendocrine cancer patients with carcinoid heart disease. Before we hear Dr. Venkatesh's presentation, we will first hear the powerful story of Jesse and his wife Ellen, who have been navigating life with neuroendocrine tumor and carcinoid heart disease, whose lives were impacted by Dr. Venkatesh's care. And after we hear Jesse and Ellen's journey, Dr. Venkatesh will deepen our understanding of carcinoid heart disease with a presentation, followed by a live question and answer session. Welcome, Jesse and Ellen, and Dr. Venkatesh.
Hi, I'm Jesse.
And I'm Ellen. Jesse's the patient. I'm the wife caregiver. And before he was diagnosed, he was very active. He paddled, outrigger canoe. We danced hula together. We played ukulele. We traveled everywhere. We loved eating different foods. And then he got diagnosed in 2018.
Yeah,
And
November.
he started on octreotide, and he's been on Afinitor, now on lanreotide, and he's been on Avastin, capecitabine, and everything went well for 5 years.
Yeah.
Relatively well, just side effects. And then he started getting really weak last year, May of 2024, losing weight, doctors saying he's just malnourished, dehydration, in and out of the ER for fluids, not really knowing what was wrong and why this was happening. And so I contacted Lisa Yen, and she advised us to go to the multidisciplinary clinic at Cedars. They immediately diagnosed him with carcinoid heart disease. Dr. Venkatesh ordered an echo with bubble, and they confirmed that he had a leaky tricuspid valve and possible pulmonary valve.
Yeah.
At first, we were told that he needed both replaced, and it would be open heart surgery. And that was really scary, as he was really weak. At that point, I was wheeling him around in a wheelchair to get from the parking lot to doctor's offices. And that was kind of fun, though, for me.
We did a lot of crashing.
Yeah, and I pushed him a little too fast, but
Yeah.
we had to get there. So he wasn't doing well and barely able to do things without getting winded. So they thought maybe open heart surgery, but he didn't need that. He got approved for the TTVR, transcatheter tricuspid valve replacement. And it wasn't really a difficult choice.
It was the choice was a life and death decision. So
You either do it or you don't.
Either do it or I'm going to die. So
We felt like that.
There's no other option. Well, I needed to have something done, and since the FDA had just cleared this, and I believe it was February 24. So and it wasn't where you had to crack the chest, and I was really happy about that. So they went through the femoral artery to install it. I went in there for a pulmonary valve replacement as well, but the doctor at that time said that the wear and tear was pretty much normal for my age group, and so they decided to not do that and just do the TTVR.
And that went smoothly. He was supposed to stay in the hospital for 2 nights, and he got out in 1 night. He did okay. He didn't start feeling any improvement for about 3 months. They said it could be a month, it could be 3, they're not sure. For him, it took about 3 months before he could drive or cook or go to the market.
Daily tasks.
Yeah, daily tasks.
So my cardiologist from Kaiser said that it's probably going to take about a year before my body completely acclimates itself. So it's just a work in progress, like you don't rush it, just work within your limitations. So that's what I'm doing now, is just working in my limitations. But I'm able to contribute. And that's the main thing, was being able to contribute to the house.
With your daily tasks.
Yeah, with the daily
He's
tasks.
a really good cook. So, when he wasn't able to cook all last year, I lost some weight because I don't cook like him. So I'm happy that he's cooking again and doing a lot of things that he couldn't do all year. And that's how life is changing for the better
Yeah.
since this procedure. And we're really thankful to Dr. Venkatesh, Dr. Hendifar, the multidisciplinary clinic for finding this so quickly and knowing exactly what to do.
Yeah.
It changed his life completely. It was not good, and we didn't know why.
Well, I think that Dr. V or Dr. Venkatesh he was a driving force behind all of this. I think, if you find yourself in a situation like this, it's a good thing to have Dr. Venkatesh in your background, because he's very tenacious, and speed is everything. And, you don't know when your ticker's going to go, and he was just pushing and pushing. He even called us when he was on vacation, from I think India.
To make sure that we were lining up everything we needed
Yeah.
to line up to get this procedure done. So yeah, he's amazing. Dr. Venkatesh made the biggest difference.
Yeah. So basically, what I take from this experience in the cardiac experience is having a great cardiologist who is very familiar with nets and try to get as many eyes as possible on your situations, because I think you can fall through the cracks very easily with this type of disease. Yeah, because you don't know. It's like, oh, this is something new. This symptom is new, and how do you deal with it? So that means to me is that you have to see the people in your team, and get it in front of them.
Stay involved with LACNets. Watch the podcast. Ask for advice when you don't know what to do.
Well, information is powerful. It'll set you free. And that's what I'm really grateful for, is to have been able to experience this with LACNets. All these incredible people that know knows who knows, and that's it. You don't know what you don't know, but these people knew what you're supposed to know.
Hello, everyone. My name is Prashanth Venkatesh. I'm a cardiologist at the Smidt Heart Institute at Cedars-Sinai Medical Center in Los Angeles, California. Thank you so much, Heather and Lisa, for this invitation and for the opportunity to present to this incredible forum. Thank you also to you and everyone involved in the Neuroendocrine Cancer Foundation for all the wonderful work you're doing to help our patients and families who have been affected by neuroendocrine tumors and cancers. To everyone listening in, patients, caregivers, and families, thank you so much for joining and for dedicating your time to this. I know that many of you have already actually submitted your questions even before the start of this talk, and so I'll certainly look to try and incorporate some of what you've asked into the presentation today. I have no financial disclosures or interests related to anything that I'm going to be talking to you about. The only disclosure I will make is that I'm incredibly honored and privileged to be part of an amazing multidisciplinary team of different types of providers here at Cedars-Sinai who really use their expertise to come together in pursuit of a common goal, which is to achieve the best outcomes for our patients with neuroendocrine cancers. So the agenda for the talk is going to be as follows. I shall first give you all an introduction to what carcinoid heart disease is. We will then delve into the details of screening and diagnosis for this condition. And finally, we will talk about the management considerations, both our conventional treatments and also some of the novel approaches that we are using here at Cedars-Sinai. So in order for us to talk about carcinoid heart disease, it's important to define a few key terms so that we are all on the same page. The first term that we all need to know about is what a carcinoid tumor is. And a carcinoid tumor is a neuroendocrine cancer that grows anywhere in the body, but most commonly in the small intestine. And this tumor produces and releases certain specific hormones into the bloodstream. And what is a hormone? A hormone is a protein that is produced in one part of the body but travels in the bloodstream to another part of the body where it exerts an effect. For instance, we all make insulin, which is a vital hormone that regulates blood sugar levels. It's made in the pancreas, but it goes into the bloodstream. From the pancreas, it travels to the liver, and it works on the liver to exert its effect of lowering blood sugar. Now, when these hormones are produced by carcinoid tumors, they're produced in excess, and the excess hormones can cause a lot of symptoms in many of our patients. And this collection of symptoms is called carcinoid syndrome. And these symptoms include diarrhea, which is the most common, but also flushing, wheezing, and lightheadedness. And the hormones that the carcinoid tumors produce include things like serotonin, histamine, and bradykinin, and there's a long list of hormones. But the hormone serotonin is highlighted because this one in particular is quite often tested and is used to guide clinical decision making. And finally, carcinoid heart disease is actually a very specific form of damage to the heart that is caused by these hormones that carcinoid tumors make. So in order for you to have carcinoid heart disease, you have to have a carcinoid tumor. So let's consider a couple of scenarios. This scenario is of a patient who has in their small intestine a single carcinoid tumor that is producing hormones. And these hormones are denoted by these blue dots. And you can see that these hormones are being produced by the tumor into the bloodstream that carries these hormones to the liver. And the liver is an organ that, among other things, does a lot of filtration of the blood. And it turns out that the liver breaks down these hormones and prevents the hormones from being released past the liver into the heart. And so in this situation, the heart actually does not get exposed to the hormones that the tumor produces. And so in a situation like this, we are not really concerned about the likelihood of the patient developing carcinoid heart disease. This is the situation where we get concerned, however, and this is where we have tumors that have broken off from the primary site in the small intestine and made their way into the liver. And now you have liver metastases. And this is a problem because the filtration system of the liver is now bypassed, and the liver tumors are able to produce and dump their hormones directly past the liver. And now the hormones are making their way up into the heart and are dispersing in the heart. And this is a situation where we worry about our patients getting carcinoid heart disease. So before we understand what carcinoid heart disease is, we need to understand a little bit about the heart and its circulation. So the heart is in the chest and it's a pump. And it has two parts, the right side and the left side. The right side collects blood from the rest of the body and pumps it into the lungs. And the left side collects blood from the lungs and pumps it to the rest of the body. So here is blue blood that is used up by the rest of the body that's coming into the right side of the heart. And this comprises of two chambers, the right atrium and the right ventricle, which pumps the blood through these lung arteries into the lungs. And as you can see, the blood changes from blue to red as it gets pumped with oxygen, and it comes to the left side of the heart, comprising the left atrium and the left ventricle, and the left ventricle pumps the blood to the rest of the body. Now, in order to ensure a one-way flow of blood in the heart, we have 4 valves, and I want you to pay particular attention to the 2 on the left side of your screen, which are the tricuspid and pulmonary valve. And as you can see, these valves are supposed to open and close in a coordinated fashion so that they're allowing for blood to flow only in one direction but not leak back in the other direction. Now here is a schematic representing a normal valve on the left, and the valve leaflets, which are basically like the doors in a double door system, are seen in yellow. And in a normal situation, these should be thin and they should be coming together nicely, and there should be no leak. When you have hormones from the carcinoid tumors that get in contact with the valve, they can damage the valve and cause carcinoid heart disease, wherein the valves roughly look like this. So the valve leaflets, as you can see, are much thicker because they're inflamed. And the inflammation over time causes these leaflets to start to retract towards their hinge point. And this is basically akin to the doors of a double door system starting to pull back towards their hinge. And this obviously leaves a big gap in the middle. And this causes a lot of leak of blood to go through that hole in the valve and cause problems. Additionally, sometimes these valve leaflets can also get stuck and may not open properly, and the valve can also be tight to a certain extent. But the most pressing issue with carcinoid valve disease is leak, also called regurgitation. Now, as I'd mentioned, the 2 valves that we typically worry about in carcinoid heart disease are the valves on the right side of the heart, and they get affected most commonly in 90% of individuals. And the reason is that, as you can see on the left side of your screen, the hormones come into the right side of the heart and then they go up into the lungs. The lungs, similar to the liver, actually have a filtration system of their own, and the lung tissue actually breaks down the hormones. So by the time the blood comes to the left side of the heart, it doesn't have any of these toxic hormones. And so the valves that we typically worry about are the ones that are in direct contact with these hormones, and that is the 2 valves on the right side of the heart. That is the tricuspid valve and the pulmonary valve. Now, there are 3 exceptions to this rule, and this comprises the 10% of patients where you can actually get left-sided heart involvement. And this is something that we need to delve into really quickly. The most common condition that we can see in this situation is a flap or a tunnel that is present in the wall that connects the top 2 chambers of the heart, which are the right and left atrium. And this tunnel is something called a patent foramen ovale, or PFO. And the interesting thing is that 1 in 4 of all human beings actually have it. Okay, so a quarter of people listening to this webinar have it, but we don't know about it. And in typical circumstances, it's never a problem, except if you have a lot of carcinoid hormones flooding the right side of the heart. Some of them may actually go through the tunnel and make their way into the left side and get in contact with the valves. Another condition is when you have tumors that get into the lungs. These are bronchial carcinoid tumors. And this is a problem because, again, similar to the liver metastases, bronchial tumors can actually bypass the lungs filtration system, and they can dump all of these toxic hormones directly into the left side of the heart. And now you have the 2 left-sided heart valves called the mitral valve and the aortic valve liable to be damaged. And rarer on the list is this situation where you have just so much of carcinoid hormone that's coming into the right side of the heart that the lungs get overwhelmed, and some of these extra hormones make their way into the left side. And in this situation where you have such a large quantity of hormones, all 4 valves may actually unfortunately get affected. Now, valve damage can actually lead to something called congestive heart failure. And this is a condition where the heart starts to get stressed because of the valve leakage, and fluid can back up in different parts of the body and cause a lot of symptoms. So these symptoms that I'm showing you are also symptoms of congestive heart failure. And they include the following: fatigue and shortness of breath. And this may range from one extreme where someone's unable to wear their shirt or to bend down to tie their shoelaces without getting short of breath, all the way to the other extreme where someone plays 2 hours of pickleball a day and now is only able to play around an hour, hour and a half of pickleball and have to stop in the middle of their doubles games to catch their breath. You can get swelling in the legs and the feet. When there is swelling in the stomach, you can actually get full quite early into a meal. You can have fluid accumulating in the belly, and this causes abdominal distension, making it hard to wear your pants or jeans. And then when the heart is stressed, you can actually have abnormal heart rhythms that can manifest as palpitations, so skipped or irregular heartbeats. And what we really want to avoid as your providers is this final symptom, which is a loss of muscle mass that can happen in patients with advanced heart failure. It is very important that patients get diagnosed and treated before this ensues. Now, putting this into perspective, how common is carcinoid heart disease? It's not very common in the general population. We're talking about 5 in 100,000 cases that actually have neuroendocrine tumors or cancers. But when you take the neuroendocrine cancer population, 30 to 40% of them have not only carcinoid tumors, but the carcinoid syndrome, which is, as I told you, the collection of symptoms that we see in patients with carcinoid tumors. And once you have carcinoid syndrome, there's up to a 50% chance that you end up getting carcinoid heart disease. This is not the whole story in the schematic, because you have some patients with neuroendocrine cancer who develop carcinoid heart disease without having symptoms of carcinoid syndrome, without diarrhea, without flushing. I would also additionally take these statistics with a big grain of salt, because I think based on the studies from which these are done and extrapolated, carcinoid heart disease is likely much more common than we think, because these patients were not being universally screened. So talking about screening, let's come to a story which is something that we hear not uncommonly. This is a timeline of a typical patient that I've seen in my clinic. On the left side, you see that the patient first gets diagnosed with metastatic neuroendocrine cancer, and they actually have carcinoid syndrome. They have some diarrhea and flushing episodes. They are stable on neuroendocrine cancer treatment for months to years. And then they start to get some fatigue, some irregular heartbeats, and some swelling in the legs. Unfortunately, there is some time lag quite often in between the testing for carcinoid heart disease being considered and ordered. And in the meantime, these symptoms start to progress. And then, thanks to insurance issues and access to care, it's some more time before the diagnosis of carcinoid heart disease is made. And by this time, the carcinoid heart disease is very severe and is associated with heart failure. And now our patients are scrambling to get an urgent valve replacement. And this is a situation that we strongly want to avoid. And the question is, can we identify carcinoid heart disease earlier? The answer is yes. And the goal here at Cedars-Sinai and other institutions is to try and catch patients before these symptoms develop in the symptom-free period. And this is where the topic of screening comes in. Screening is basically testing that we do to find a disease in somebody who is at risk for that disease but not having symptoms of that disease. For example, a female patient in their 50s may need a breast cancer screening via a mammogram, even if they're not having any symptoms of breast lumps. The diagnosis is done by testing that finds disease in a patient who's having symptoms that are suggestive of that disease. So if you have a breast lump, then you would need to get targeted diagnostic testing to rule out breast cancer. And the testing that is used for either of these may not be the same. So for example, a mammogram is a common screening tool, but a breast MRI is a common diagnostic tool that is not used as a screening test. What do we do here at Cedars-Sinai for carcinoid heart disease screening? So we tend to be a lot more aggressive and a lot more liberal because we have seen a lot of carcinoid heart disease and we strongly believe that it's important to catch patients earlier, as I just mentioned. So who do we screen for? We screen patients with metastatic carcinoid tumors that produce serotonin, regardless of whether or not the patient has carcinoid syndrome. This is very important. Many of the times, patients may have very high serotonin levels, and rarely this can happen in patients without metastatic disease. Even in that situation, they typically would have carcinoid syndrome and we would screen them anyway. But the presence or absence of carcinoid syndrome does not determine necessarily our screening tactics. Now, how do we screen? There are two ways of screening. The current guidelines actually recommend the first one only, which is a blood test. But we do both blood test and an ultrasound scan of the heart, which is called an echocardiogram. What is the blood test that we do? We test for one of these two proteins, NT-proBNP or BNP. And these are basically proteins that the heart makes when the valve leaks. The heart makes these proteins anyway, but when the valves are leaking, the heart muscle gets stretched out and it produces excess amounts of these hormones or proteins that are then detected in the bloodstream. And the question then becomes, how often do we repeat these tests? We may do it annually. We may do them every 6 months. We may do them as often as every 3 months. And this is really based on the patient. And it's based on your serotonin levels or how bad the carcinoid syndrome is, the amount of liver metastases you have, and also what the initial echocardiogram showed. If you already have evidence of moderate carcinoid heart disease, we should probably be screening you every 3 to 6 months. And that's because carcinoid heart disease, when it happens, can progress very quickly. Moving on to ultrasound of the heart, because I mentioned that to you a few minutes ago. The workhorse test that we use very commonly in our clinics is something called transthoracic echocardiography. Echocardiography means ultrasound of the heart. Transthoracic means across the chest. So as you can see in this pictures, a patient is lying down and we have a sonographer to their right who is basically placing an ultrasound probe at strategic points in the chest. And this generates pictures and videos of the heart. And with this, we do complete evaluation of all the 4 valves in the heart. And we use something called color Doppler, which is a technique that we use to evaluate for the blood flow across the valve and to check for leakage. And we do something called a bubble study to check for a PFO, which, as I told you, is a patent foramen ovale. That's the flap that 1 in 4 of us have in the wall separating the top 2 chambers of the heart. And we need to know whether or not you have it. And the way we do it is we put an IV in your arm. We inject through the IV line saltwater bubbles. And these bubbles pass into the right side of the heart, but shouldn't be seen on the left side, except if you have a PFO, in which case these bubbles can actually cross through the PFO, through that flap, go into the left side of the heart where we can detect it on ultrasound. This is what an echocardiogram looks like. And I want to focus your attention to the left of the screen, where we have a normal patient of ours who has a normally functioning tricuspid valve. So you can see in between the right atrium and right ventricle, there is a mobile door-like structure that opens and closes, and this is the tricuspid valve. You can see the two parts of this valve on this picture coming together very nicely with no gap in the middle, and these leaflets or the doors of the valve are nice and thin. The next picture is a color Doppler picture. And I will just tell you, we're basically looking for any blue color inside the right atrium. And as you can see, there is a very, very tiny amount of blue that seems to come and go. And this is because this patient has a tiny amount of leak of this valve, which is normal or physiologic. We would all be expected to have a tiny amount of tricuspid valve regurgitation. The issue is what's happening on the right side of the screen. This is our patient who newly presented with carcinoid heart disease. And as you can see, look at the valve in between the right ventricle and right atrium, which, by the way, are very big in this picture. The valve is pulled apart. There is a big gaping hole through the middle of the valve, and the valve leaflets are really frozen in an open position. They're really not moving. And on the picture on the extreme right, you can see a massive amount of leak. So all of that blue and yellow color that's going into the right atrium represents a severe or a torrential amount of leak that is going into the wrong place. And this patient certainly had evidence of congestive heart failure, which can happen when the leak becomes very severe, as in this case. Additionally, we have advanced techniques that we can use to get three-dimensional pictures of these valves, and this gives a different perspective. So on the left side, you have a normal tricuspid valve with nice and thin leaflets. You can't even see the complete extent of the leaflets because they're so thin, and that's normal, but they're coming together nicely as compared to the picture on the right, which is of a patient with carcinoid heart disease. And you can see that this valve is completely stuck open, and there is a big black hole in the middle of the valve, and that's basically through which you have a lot of leak. And these are, again, our patients here. And we're able to generate this using our latest three-dimensional echocardiography technology. Now, many of you had asked me what the pitfalls of echocardiography can be and how do we know if the echocardiography is adequate or not. And the answer really has to do with the second valve on the right side of the heart, which is the pulmonary valve. Now, the pulmonary valve is situated between the right ventricle and the pulmonary artery. And look at the left side of the screen. This is a patient where you can see a very thin pulmonary valve. So if you peel your eyes to the middle of that screen, in between those two labels, there is a tiny, very thin white line that you can see coming in and out. That is the pulmonary valve, okay? And it's hard to visualize, as you can see. But what we often see is what you're seeing on the right side of your screen, where our patient is trying to get this imaged, but you can't really see the valve at all. And this can happen in up to 50% of cases where the valves may not be visualized. And so we have multiple challenges with the pulmonary valve. It is unfortunately called as the forgotten valve. And the reason why it's called so is because most cardiologists and sonographers in practice do not see much pulmonary valve disease on a daily basis. And I'll safely say that because I'm an adult echocardiographer as well. And because we don't see as much of this, only one view in most protocols that sonographers use to scan you is dedicated to the pulmonary valve. The other three valves that are much more commonly seen have all of these other views, 4 to 6 views, where if you don't find the valve in one, you can find it in 4 other views. And then on top of that, the valve is difficult to image because of interference of the lung and so on. And so what is the end result? We may not image the valve adequately, and we may end up underdiagnosing carcinoid involvement of the pulmonary valve. And this is a problem. Now, why did I say that we don't typically see pulmonary valve disease in adult cardiology? It's because of this. Look at these two pie charts, one representing pulmonary valve leak and one representing pulmonary valve narrowing or stenosis. The red part tells you that the overwhelming majority of pulmonary valve disease happens in people with congenital heart disease or birth defects that you were born with, okay, of the heart. And so congenital cardiac patients typically get seen in specialty practices and not in the general cardiology practice. And so this is an issue. Why is it an issue? Because on the flip side, look at patients who have known carcinoid heart disease. And this is the bar chart on the right of your screen. 97% of patients have tricuspid involvement, but 88% of patients also have pulmonary involvement. So if you have tricuspid carcinoid, you're likely also going to have pulmonary valve carcinoid. And so if you're not seeing these valves properly, the concern is that we may not diagnose it well enough and in time. So what are we at Cedars-Sinai doing to overcome this challenge? Well, we have a unique setup where we have a nationally accredited adult congenital heart program. And it turns out that I myself am an adult congenital cardiologist. That's my primary trade. So we have access to specialists as well as specialist sonographers who have experience in looking for and diagnosing pulmonary valve disease. And so pulmonary valve disease in our practice is very commonly seen because we see a lot of patients with congenital heart disease. And so if we need advanced imaging, because sometimes the congenital sonography is not good enough, we can actually do that with our own specialists. And we partner very closely with our oncology colleagues. So here is an example of a patient on the left side of your screen who had an echocardiogram done through the regular adult protocol. And the rest of the pictures were excellent. And this is a patient who has known tricuspid involvement with carcinoid. So they likely have pulmonary valve involvement as well, based on the statistics that I just showed you. But on the color picture on the left side of the screen, you can hardly see any red color in the very middle of the picture. And so this patient was diagnosed as having anywhere from a tiny amount to a mild amount of leak, in which case we wouldn't need to do anything about it. The same patient the next day gets a congenital echocardiogram using an unconventional view because, as you can see, the one on the left, the conventional one, was inadequate. And so now we can see a lot more leak, which is all of the red color that's flowing into where the arrow is pointing. And you can see that there's a lot of leak. And so this is the power of congenital sonography when it is used in patients with suspected carcinoid heart disease with pulmonary valve involvement. Sometimes this is not enough either, and we can do some additional testing as part of our congenital heart program. So on the right of the screen, you can see some scanning tests done. So there's a CT scan and there's an MRI scan. And so this certainly can be done to give some additional information. But quite often what we end up doing is the two things on the left of the screen, which is an echocardiogram on the top left done through the mouth. And the echocardiogram probe is passed into the food pipe or the esophagus with the patient under anesthesia, and we're able to take a closer look at the pulmonary valve that way. It can still, however, be challenging. And on the bottom left, we have a technology called intracardiac echocardiography. And this is something that many institutions have access to, but are typically not using for diagnosis of the pulmonary valve. But we see immense power in this technology because this involves taking a camera into the heart through the blood vessels in the leg. And we're actually able to take a camera and put it right under the pulmonary valve. So it's like taking a close-up picture of someone's face as opposed to trying to zoom in from 200 feet away. And we're able to get excellent pictures. And we don't do this in everybody, but we do this in situations where transthoracic echo, which is echo done across the chest, is not enough. So here's a patient with carcinoid valve involvement of the tricuspid, where the pulmonary valve was not able to be seen. So we took this patient for a transesophageal echo, where we put the echo probe through the food pipe. And what we can see here on this picture is that the pulmonary valve is severely leaky. On the right side is a three-dimensional picture of the same pulmonary valve that clearly shows you a big hole in the valve, which is that black hole in the middle. And that shows you why there is leak. And it's not easy to get these pictures, but we again have expertise and we have protocols specifically designed to look at these pulmonary valves for you. In some cases, we are obliged to do an intracardiac echocardiogram, which is that echocardiogram done through the heart, from inside the heart. And now you can see the pulmonary valve very clearly, and you can see that it is not coming together, and there is a big gap with all of that red and yellow blood that's leaking back into the wrong side. And again, you can see a big hole in the valve on the picture on the right side of the screen, which is a three-dimensional echo. So let's talk about who needs intervention for carcinoid valve disease, and that's what I'm going to talk about in the remaining time that we have. So who needs it? Any one of the following situations. So if you have symptoms that are known to be because of your valve condition, you need a valve replacement. If you don't have symptoms, but the heart on the ultrasound scan, on the echocardiogram, is starting to get bigger and bigger, or it's starting to get weak, then we need to go and fix the valves. And finally, if you need liver surgery for a neuroendocrine cancer, sometimes the valves may need to be replaced in order to make the surgery safer for the liver. And the question is, how do we take care of the valves? The conventional answer is surgical valve replacement. And surgical valve replacement is done via an open heart surgery. And so the chest is opened, the heart is opened, the diseased valve, as you can see in the middle of your screen here, is taken out of the body. And on the right of the screen, you see a brand new, beautifully functioning artificial heart valve that is implanted. These valves are made of biological material, which are either pig or cow tissue. And this is the standard valve type that we use and most centers at this point use. Now, how does surgical valve replacement perform for patients with carcinoid heart disease? And what are the statistics? At an advanced center like ours or the Mayo Clinic, from where these statistics come, the operative mortality, which is the 30-day mortality after surgery, is around 5%. This is important to know because this is not typically considered low-risk surgery. This is considered intermediate-risk cardiac surgery. But this is still acceptable risk for most of us. However, it's important to take that into account when considering the second bullet point, which is that surgery actually reduces long-term mortality by slightly over 50% compared to getting no intervention on the carcinoid valve disease. So it's important to consider this option if you have symptoms of severe carcinoid valve disease. And in the long term, patients actually do quite well in terms of how the valve works. So there's around a 7% incidence of needing another valve replacement at 6 years. And there's only a minority where the carcinoid affects the artificial heart valves. But what is important to consider is that surgery may not be for everyone. And there are some people who are at higher risk when they get the surgery compared to others. And those higher risk conditions include if you're older, if your heart failure is more advanced, if your kidneys don't work well, and the kidneys may actually be affected by heart failure, or if the heart is really large in size. Again, because these symptoms have gone untreated for too long. And so the question is, do we have any options for that kind of patient? And the answer is yes. And so the complete picture is this. At Cedars-Sinai, we offer both surgical replacement and transcatheter replacement. This is a newer technology. And what is transcatheter replacement? This is replacement of the heart valves that is done through a minimally invasive approach. As you can see on the left side of the screen, the entire procedure is performed by an interventional cardiologist using a large IV line that is typically inserted into the large vein in the groin. And so most of the entire procedure, in fact, can be done through these large IV lines without opening up your heart. And this is accomplished, as you can see in the middle of the screen, by real-time X-ray imaging. And so we're actually able to see where the equipment is inside the heart, and we're able to maneuver the equipment and the valves with great precision. And on the right side of the screen are some commercially available and approved valves that are used for tricuspid or pulmonary valve replacement. So let's talk about transcatheter replacement of the pulmonary valve. And as you can see on the video on the left, the valve is actually able to be taken into the heart and positioned across the patient's own pulmonary valve through a catheter. And the valve is able to be deployed using a balloon that is inflated to keep the valve open. And then the balloon is deflated and taken out of the body. And the valve technology is such that it allows the valve to be seated in place and essentially stuck in position permanently. And so that valve will stay in there forever. And the valve that we would implant, again, is a biological valve, either made from cow tissue or pig tissue. And this technology was approved for the pulmonary valve in the year 2010, since when we have multiple devices that have been approved. Importantly, this is done best by a congenital interventional cardiologist. We have a world-class congenital interventional cardiologist here at Cedars-Sinai in Dr. Evan Zahn and his amazing team. And again, this is where we leverage the expertise of our congenital heart team in caring for our patients with carcinoid heart disease. The immediate implantation success rate is around 98%, and patients in the long term are known to do quite well. only around 6% need a new valve at 5 years, but around 20% need a new one at around 10 years. Importantly, unlike surgery, there are no long-term data of this technique in patients with carcinoid heart disease. We here at Cedars-Sinai are hoping to publish our outcomes, which are quite promising, but we don't have 10 or 20-year data like we do in surgical valves. And this is the newest kid on the block. This is transcatheter tricuspid valve replacement. This is a technology where, similar to the pulmonary valve, the tricuspid valve is able to be deployed. An artificial valve is deployed using hooks that you can see hook under the patient's own tricuspid valve, and the valve is then able to be released, and now you have a brand new valve in place of the one that was affected by carcinoid. This also is a biological valve, and we only have one device in the US because the commercial approval only took place a year ago. This is done by an adult interventional cardiologist. And again, we have a world-class team headed by Dr. Raj Makkar, who was instrumental in bringing this device to market. And therefore, we here, our Carcinoid team, has excellent expertise in doing even complex cases of transcatheter tricuspid valve replacement in patients with challenging anatomy. And the immediate success rate is around 98%, though these statistics don't necessarily apply to carcinoid patients. In fact, some patients with carcinoid heart disease may not qualify for this procedure because of anatomic issues, and this is very important to underscore. Additionally, there are some complications. There's a 13% rate of needing a pacemaker, but this was described in the original trial. And as we get more experienced with this, the likelihood of needing a pacemaker will get lower in all likelihood. And at 1 year follow-up, we know that these valves do really, really well. Again, these are data in patients without carcinoid heart disease. So for you, the patient, we have multiple considerations. With a surgical valve replacement, this of course is major cardiac surgery with a longer recovery in and out of hospital. You do need to be robust enough to be able to withstand this. We also, on the plus side, have extensive experience and data when it comes to long-term outcomes after surgical valve replacement in patients with carcinoid heart disease. And if you need a future valve, that can be done minimally invasively through the transcatheter approach. But if we're starting off with a transcatheter valve replacement, the advantages, of course, are that this is a minimally invasive technique with a much quicker recovery, and this can therefore be an attractive option, especially for those who may be too high risk or at a higher surgical risk. And it is important to underscore that we don't yet have long-term data in patients with carcinoid heart disease, and there are some anatomic exclusion criteria that may not allow you to qualify for this procedure. But we here at Cedars-Sinai have been pioneers, thanks to our colleagues in interventional cardiology, of a completely transcatheter approach that we are now able to offer due to our combined collective expertise. So how does this all tie in for you, the patient? If we determine that you have an indication for surgery, we typically have both our surgeons and our interventional cardiology team assess you. We then come to the drawing board and have a heart team discussion. And this is crucially important to make sure that everything, including your risk for either procedure, as well as your preferences, as well as the expert opinions of our team, are taken into account. And this then would lead to our recommendations of either a surgical valve replacement or a transcatheter approach. And in a transcatheter approach, we would do both the pulmonary and the tricuspid, but in separate procedures in sequence. And we would typically do the pulmonary first, wait around a month for your heart to heal, and then do the tricuspid. And this is really thanks again to our wonderful multidisciplinary team, who I am truly indebted to for their support and perseverance when it comes to taking care of our patients with carcinoid heart disease. Thank you also to the Neuroendocrine Cancer Foundation for this opportunity. And above all, thank you to all our patients, families, and caregivers for your support and trust.
Thank you, Dr. Venkatesh, for that incredibly informative presentation. We learned a lot from you, and I'm really excited for this question and answer session. So thank you for joining us again for this question and answer session. And just a reminder to our audience, this question and answer session is for educational purposes only. It does not substitute for medical advice. Please talk to your medical team with your questions or concerns about your individual care or treatment. There are approximately 20 questions. We'll try to get to as many general questions as possible on this topic. And please note that we will address broad-based questions only and cannot provide specific feedback on your specific situation. Also, we will not necessarily address the questions in the order they were submitted, but instead in an order that makes sense. So, Dr. Venkatesh, thanks again for joining us. And
Thank you,
we're
Lisa,
really
for the
grateful for
opportunity.
we're really grateful
I
for your
appreciate it. Thank you.
expertise. I'm going to start with the questions, if that's okay with you. And I know you covered this already, but I think this is an important question to answer because there's a lot of concern about carcinoid syndrome and then carcinoid heart disease. So does one have to have carcinoid syndrome in order to have carcinoid heart disease? And then I guess, how does that apply to me, right? How do I know if I'm susceptible to carcinoid heart disease?
That's an excellent question. The answer is no, you do not have to have carcinoid syndrome to have the heart disease. It is certainly a lot more likely that you would have carcinoid syndrome if you have carcinoid heart disease, because typically the reason why you have carcinoid heart disease is because of an excess of serotonin hormones. And serotonin hormones, if they're produced in excess amounts that are enough to cause heart disease, typically they will also cause the syndrome. We certainly have seen a small number of patients who have carcinoid heart disease without the syndrome. And so it's important to keep that in mind when counseling and deciding for screening with respect to patients with carcinoid tumors. So the susceptibility really comes in with respect to whether or not you have a serotonin producing tumor that is metastatic. So if you have metastatic neuroendocrine cancer that produces serotonin, and you have metastatic disease in the liver, or you have primary bronchial carcinoid tumors, you would by definition be at risk for having carcinoid heart disease.
Okay, thank you for that and for clarifying. And I know you mentioned some of the symptoms that might indicate carcinoid heart disease. So could you also kind of go back to that? Which of the specific symptoms to look out for that might indicate that? And also as a follow-up, like, how do we know that these symptoms are specific to carcinoid heart disease?
That's the second part of that question is incredibly important to emphasize, because the symptoms of carcinoid heart disease are often quite non-specific in our patients who already have symptoms from carcinoid syndrome. So the main symptom that we see is a change in people's ability to perform exercise and to do physical activity. So I mentioned the pickleball example in that presentation, but essentially the changes can start off as being fairly subtle. Like someone's unable to lift weights and say throw out their trash, but they're otherwise able to walk normally and walk up and down stairs, and then it sort of starts to progress from there. So a subtle decline in functional capacity is quite often the first thing that we see. But that, of course, can happen if, for instance, the neuroendocrine cancer is starting to progress. So that's certainly a finding that is sensitive but not very specific. Additional findings that can be more specific include symptoms of congestion. So once you start to have swelling in different parts of the body, including the legs and the abdomen, and certainly in the stomach, where you end up not being able to finish your meal that you would otherwise be able to finish because you get full too early, that particular symptom we have noticed is fairly specific for congestive heart failure on the right side of the heart, which would then indicate carcinoid heart syndrome again. If there is a large neuroendocrine metastasis that is pressing on the stomach or displacing the stomach because the primary tumor in the bowel is so large, you can obviously have a decreased capacity in the stomach. And so I would say that none of these symptoms are entirely specific, but the important things to remember are what symptoms you used to have from the neuroendocrine cancer alone, and whether or not the symptoms of concern are new symptoms that might potentially indicate development of heart disease. Certainly raising this with your provider, with your oncology provider, is important so that they can screen you for carcinoid heart disease if any of these symptoms are concerning.
Yeah, that's helpful. Sensitive, but not necessarily specific, and really looking at new or worsening symptoms.
Absolutely.
Okay. What about irregular heartbeat and pounding heartbeat in the chest, and also neck signs? Would these be symptoms of heart valve disease, and what could cause these?
Once again, this is a very non-specific symptom that can certainly herald valve issues in patients with carcinoid heart disease that were otherwise undiagnosed. So if you're having some of these symptoms that I've already mentioned and you're having irregular heartbeats and you're at risk for having carcinoid heart disease, that is certainly something to consider. That being said, several different reasons can be responsible for irregular heartbeats. So for instance, if you have a neuroendocrine cancer and that is causing diarrhea as a manifestation of carcinoid syndrome, the diarrhea can cause dehydration, which can cause abnormal heartbeats. It can cause a depletion of potassium and magnesium levels in the blood because they're being wasted out in the stool. And that can also cause abnormal heart rhythms that can cause these irregular heartbeats and pounding sensations in both the chest and the neck. Anemia from either the neuroendocrine cancer or from the therapies that some of our patients get for this can cause abnormal heart beating. And of course, some of the therapies have arrhythmias as side effects, such as some tyrosine kinase inhibitors are known to cause certain forms of arrhythmias. So you can have irregular heart beating and pounding sensations for many reasons, but carcinoid heart disease is certainly one of them.
And there may be overlap with this question, but what about
Yes.
atrial fibrillation or the irregular heart rate? Could that be a symptom even if the serotonin wasn't particularly high?
So atrial fibrillation in our patients over the age of 50, particularly over the age of 60, is quite common and is essentially an age-related condition of the heart. And as you age, you start to form scar in the top parts of the heart especially, and this can cause atrial fibrillation to develop even if you have no evidence of other valve problems or other heart issues. So you can certainly develop atrial fibrillation regardless of whether or not you have any other medical conditions. If you have a neuroendocrine cancer that is producing serotonin, palpitations can certainly be, and abnormal rhythms can potentially be triggered by very high levels of these circulating hormones. If the serotonin levels were not particularly high, the question is how high they were. And if you do have a truly serotonin producing neuroendocrine cancer, then you are theoretically at risk of carcinoid heart disease, assuming that neuroendocrine cancer is metastatic to the liver, or if the serotonin levels are very high. So if you don't have a very high level of serotonin, if you have low levels and the tumor is not in the liver and you don't have bronchial carcinoid, if it's just confined to the small intestine, the atrial fibrillation is on its own unlikely to influence our assessment of your risk of developing carcinoid heart disease.
And is it harder to diagnose carcinoid heart disease if someone has atrial fibrillation?
Not necessarily, because the testing for carcinoid heart disease would be independent of rhythm issues. It would be an echocardiogram regardless. And so if there's any concern, you can have abnormal echocardiograms be assessed pretty adequately, even in people with atrial fibrillation. If the atrial fibrillation is uncontrolled, so if somebody is having very fast heart rates while they're in atrial fibrillation, sometimes the diagnosis of valvular regurgitation can be challenging. But if you have atrial fibrillation with heart rates that are relatively in the normal range, say less than 100 beats per minute or so, you can make a pretty good diagnosis or have a pretty good certainty of making a diagnosis of carcinoid heart disease on echocardiogram, if that's a concern.
Thank you. Thanks for that. You've mentioned serotonin a couple of times, and just want to clarify, is serotonin the only hormone that causes carcinoid heart disease?
No, most likely not. It is the hormone that is most commonly tested for. It is also the hormone whose byproduct, which is 5-HIAA, that is present both in the blood but commonly tested for in the urine. These tests are actually known to have the greatest amount of correlation with respect to development of carcinoid heart disease. So other biomarkers and other hormone levels have been studied, chromogranin A being one of them. But there are many, many hormones that some of which have been tested as biomarkers to track either the incidence or the progression of carcinoid heart disease. And the one that really pans out as being the most reliable is serotonin, and more specifically, the byproduct of serotonin, which is 5-HIAA. carcinoid tumors, as I mentioned, can produce a whole host of hormones, not just serotonin. And it is likely that the other hormones also have somewhat of a role in the genesis of carcinoid heart disease.
A couple other symptom-related questions. Is low heart rate, plummeting blood pressure during surgeries, any surgery, a possible symptom or sign of carcinoid heart disease, especially if someone has had a small intestinal neuroendocrine tumor?
No, that is not necessarily a sign of carcinoid heart disease. That is more a sign of the total amount of serotonin that you have in your body and the amount of, more specifically, the amount of serotonin producing tumor burden that you have. What is being described in this question is something called a carcinoid crisis, where in response to the stress of a surgery, tumors that produce serotonin and other hormones release their carcinoid hormones in a large surge. And that surge, the sudden surge of hormones into the bloodstream, can often cause blood pressure to drop precipitously during the surgery. And this can occur independent of whether or not you have any heart involvement. That being said, if you do have a significant carcinoid heart disease and you're having a carcinoid crisis, the presence of severe valve leak and consequent problems with the heart's function, heart failure specifically, can certainly add to the challenges of controlling the blood pressure during the surgery.
On the flip side, what about difficult to control high blood pressure? How does that enter into possible symptoms?
So, in a rare minority of cases, patients with carcinoid flares can actually have episodes of high blood pressure and not low blood pressure. Typically, these hormones actually function as vasodilators. And what that means is that the blood vessels throughout the body essentially tend to enlarge and get floppy and lose their tone. And that's basically why the blood pressure drops and why you have dizziness or lightheadedness, why you have diarrhea, because water actually leaks out from these enlarged blood vessels and enters the gut. And so that's basically why you have diarrhea and carcinoid syndrome. A small minority of cases can present with high blood pressure, especially during carcinoid crises. But I would make sure that in your specific case, that actually is representative of a carcinoid symptom rather than hypertension, which is a separate condition that you might have irrespective or regardless of the neuroendocrine cancer. I will say that if you have hypertension and neuroendocrine cancer at the same time, then blood pressure medications that you're taking to lower blood pressure for hypertension purposes can potentially interact if you have carcinoid hormones that are not controlled adequately, and those are causing episodes of low blood pressure. So on the one hand, you have high blood pressure for which you're taking medications. On the other hand, you have carcinoid syndrome that may cause episodes of low blood pressure. So a balance would have to be achieved with your oncologists and your primary care or cardiologist's input with respect to adjusting doses of these medications so that symptoms and blood pressure can both be controlled in an optimal fashion.
Yeah, it can be a confusing picture. Yeah.
Certainly.
So let's shift to some questions about echo. I know you spent a lot of time sharing your expertise about echocardiograms. And this is a question that got upvoted, so on a lot of people's minds. How do I know if the echo I'm getting is good for looking for carcinoid heart disease? What should I be asking to ensure I'm getting a proper echocardiogram?
That is an excellent question for a couple of reasons, but I'd say the most important thing is that our patients are being advocates for their own health, which I strongly encourage. So I think knowledge is power, and it's important to ask and make sure of your physician that or your cardiologist that you are getting the adequate amount of testing, which is pertinent for this talk for sure. So it's the main issue, as I mentioned, is the pulmonary valve. So you want to make sure that all of your heart valves are being assessed and that the pulmonary valve is being seen adequately, and an adequate amount of confidence can be obtained with respect to the assessment of whether or not the pulmonary valve has any involvement of carcinoid. Additionally, in individuals with concern For left-sided carcinoid, this is also important because you want to make sure that a bubble study is done for anyone who's getting a screening echocardiogram, just a one-time bubble study to make sure you don't have a PFO. If you do have a PFO, it's important to look at the left-sided heart valves closer than you otherwise would for carcinoid involvement. And so those are the main things that you want to be looking for: pulmonary valve assessment and the presence or absence of a small flap in the heart.
Thank you for that. You mentioned the congenital echocardiogram. Do I need to specifically ask for a congenital echo or find a congenital cardiologist to look for carcinoid heart disease?
No, that is not necessary. The reason why the congenital aspect of things came into discussion was really to discuss how we here at Cedars-Sinai are able to tackle the challenge of inadequate visualization and assessment of the pulmonary valve in our patients. I think the bigger issue is that you want to have a clear assessment of whether or not the pulmonary valve is seen and whether a clear determination can be made as to its involvement with carcinoid. If the answer is that you cannot see the pulmonary valve adequately on a regular adult echo, that is fine, but you want to make sure that additional testing is done. And that additional testing does not need to include an intracardiac echo, which may not be done at many other centers, but for instance, a cardiac magnetic resonance imaging scan, a cardiac MRI scan, is a very useful test that can be obtained in most academic and community centers in 2025. And the pulmonary valve can be assessed quite reliably by a cardiac MRI, and the amount of leakage can certainly be assessed. So you don't need a congenital echo necessarily. A properly done adult echocardiogram may suffice, and even if it doesn't, the important thing is to have follow-up testing.
Thanks. That's helpful. What about post-neuroendocrine tumor surgery? How do the cardiologists know if your heart disease or heart issues post-NET surgeries are carcinoid heart disease, and what would you check for?
So carcinoid heart disease after NET surgery. So certain NET surgeries in the acute setting can, of course, cause carcinoid flares and such. I would say if at all there are concerns for carcinoid heart disease, not only do we look for the amount of leakage, we also look for changes in the anatomy of the valve. So if there's evidence of thickening and inflammation and signs that the valve leaflets are starting to go back and retract towards their hinge points, like I mentioned on that on the slide, those are sort of clues that will tell us that there is some carcinoid heart disease developing. So it's both the function of the valves, but also what the valves look like anatomically. And that can be seen on echocardiogram and MRIs and other tests.
So back to the echo.
Yes.
What about for lung? How is this different with lung? I mean, this person asks about this specific case, but in general, what's the best test for heart valves for the lung? And this person had a left lung removed with no visibility on the echo, but there was fluid in the lung space.
Yes. So the bronchial carcinoid is one of the rare situations where you actually can have the left-sided heart valves be affected by carcinoid heart disease. And this is because these tumors actually produce their carcinoid hormones into the bronchial veins that then go directly into the left side of the heart. So the filtration system of the lungs that typically break down these hormones that come from the right side of the heart are really not involved in this. So the best test for the heart valve still is an echocardiogram, unless there are challenges in visualizing the valves. The focus in a situation like this should be not only on the right-sided heart valves, but specifically on the left-sided heart valves, because they're the ones that are going to directly see the impact of the carcinoid hormones that are coming in through the blood vessels from the bronchial carcinoid tumor. The good news is that the left-sided heart valves are much easier when it comes to assessment compared to the pulmonary valve. So the mitral and the aortic valves can be seen much easily, and you can certainly get adequate information using a transthoracic echo.
So if someone has known carcinoid heart disease, what are the blood tests that you would need to look at, and how regularly scheduled to keep an eye on the heart function health, as well as EKG and echoes?
The blood tests that you would need to look at are primarily the two that I mentioned with respect to the proteins that the heart makes when it's stretched. And those are the NT-proBNP test and the BNP test. You don't need both, you only need one or the other, but it's important that you just get one that is consistently followed. So don't get BNP one time and then an NT-proBNP at another time, because then you're comparing apples to oranges. This test is best done every 6 months if you are at risk of, or if you already have carcinoid heart disease. If you already have carcinoid heart disease, you might need that test to be done more frequently, more often than every 6 months, based on how bad the carcinoid heart disease is. And the same thing for echocardiograms as well. If you're just at risk for carcinoid heart disease, echocardiograms could be done. Again, depending upon who you ask, we here at Cedars-Sinai might do it annually. The guidelines just recommend doing an echocardiogram if the NT-proBNP level is elevated. There are some false negative results of the NT-proBNP tests and the BNP tests, which is why we tend to err on the side of doing more echocardiograms here. But again, if you have carcinoid heart disease, the echoes may be done as frequently as 3 months, or as frequently as annually, or any sort of interval period in between that.
That's a good point to highlight, that whether or not you get a pro-BNP, NT-proBNP, or BNP, that you stick with the same one. What about
Correct.
the EKG? Can you also clarify what's the difference between an EKG and an echo, and when might an EKG come into play?
Thank you for asking that. So an echocardiogram is an ultrasound scan of the heart, and EKG stands for electrocardiogram, which is a different test that purely looks at the rhythm of the heart. So that is a quick test that is obtained by putting stickers on the chest in specific locations, and a snapshot of the heart rhythm is taken. So all an EKG assesses is heart rhythm. It does not tell us whether or not there is valve disease. It does not give us a direct photograph or a picture of the heart, unlike an echocardiogram. So an EKG, if you're having palpitations, for instance, if you're having irregular abnormal heartbeats, and there is a concern that your heart rhythm may be abnormal, an electrocardiogram is the preferred test to get. If there's a concern that there is an issue with the structure or the function of the heart, then an echocardiogram is what needs to be done.
That's helpful. Structure and function. Go to an echo.
Correct.
Okay. What about those people who've already had valve replacement? So, for example, this person already had tricuspid and pulmonic prosthetic valve replacements in the past. What questions should I be asking my cardiologist?
So once you have your tricuspid and pulmonary valve replaced with bioprosthetic valves, the main thing to look out for is whether those bioprosthetic valves are starting to malfunction in any way, or if they're working well. The two ways that the valves can malfunction is they can start to get leaky, or they can start to get tight, which is basically the two ways that any valve can fail, even in someone without a valve replacement. And so that is, again, something that can be ascertained with an echocardiogram. And once again, just like with your own pulmonary valve, if you have a bioprosthetic pulmonary valve, that may also not be seen clearly on a transthoracic echocardiogram. So it's important, again, to ask your cardiologist whether they're able to see and assess the function of the pulmonary valve with equal confidence as the tricuspid valve, and whether or not additional testing is needed. Of course, the other consideration is if you've had tricuspid and pulmonary valve replacements, and say you have a patent foramen ovale, a PFO, that was for some reason not closed, then the other question is whether or not there is any concern for involvement of the left-sided heart valves that in this particular case have not been replaced. And so in addition to looking at the valves that have been replaced, if there is concern to look for the other two valves on the left side of the heart, that should also be taken into consideration.
Thank you. This is a great question. In carcinoid heart disease, why is the tricuspid valve replaced versus repaired?
Yeah, excellent question. In cardiology, as a rule of thumb, in most cases, if you are able to repair the valve, fix the valve without actually taking it out and putting a new artificial valve in, that is always preferred, on one condition. and that is that the valve is actually amenable to repair. Because what you don't want to do is to repair the valve and then have the repair fail in 6 months to a year. So the question that is facing cardiologists and cardiac surgeons in particular, when they look at valve disease, is this valve amenable to repair, and is it amenable to a durable repair? And the problem with carcinoid heart disease is that by the time you have significant enough valve dysfunction that requires surgery, the leaflets of the valves too thick and inflamed and damaged by these hormones to be able to be fixed or to be able to be repaired. The only way that you can actually reliably take care of the leakage that these valves are having is to take them out completely. So it's specific to the disease process and the inflammation and the thickening of the valve that happens in carcinoid heart disease because of the actions of the hormones, as to why repair is really not possible in most cases with carcinoid heart disease.
Thank you. And another applicable question, do you put your patients on blood thinners, for example, warfarin, even if they are replaced with tissue valves, and why or why not? And then if needed, how do you decide which blood thinners to use?
Yeah, this is an excellent and a nuanced question because there are a couple of parts to this. So for those who do not know about warfarin is a different type of blood thinner compared to aspirin. And these are two different blood thinners that are quite often used in people who have had valve replacements based on the type of valve and the location of the valves. The standard practice for long-term maintenance after a bioprosthetic or a tissue valve is aspirin, typically at a dose of 81 milligrams per day. Again, this can vary, but typically baby aspirin or 81 milligrams daily of aspirin. Warfarin is an entirely different medication that is a lot stronger. And the question then becomes, are we giving patients additional benefit by putting them on long-term warfarin? I will say that it's quite often that surgeons recommend a 3-month course of warfarin after a valve replacement surgery. And that is really to protect the valve in its vulnerable period that is certainly within the first 3 months or so when it comes to forming blood clots on top of the valve. It is unlikely that we would see routine practice where warfarin is maintained in the long term, except in a situation where, say, aspirin did not work for some reason and someone ended up with premature failure of the valve, say in 2 or 3 years' time, which is unexpected. And if that were to happen, one can consider doing something like long-term warfarin for the next time they get a valve replacement. There are no long-term data suggesting that long-term warfarin is superior to long-term aspirin for a bioprosthetic valve in patients with carcinoid heart disease. Those data don't exist. And we have to balance the potential theoretical benefit that warfarin might give with respect to valve longevity against the known non-theoretical risk of increased bleeding that patients can be subjected to and are subjected to with warfarin over aspirin, especially if we're talking about individuals getting procedures and surgeries for their neuroendocrine cancers. So it's a nuanced answer to a nuanced question, I hope.
Yes, challenging. Yes, this is why it's helpful to have experts, I guess, reviewing the case. This is another good question. Are there cases when you would just replace the tricuspid valve, even though the pulmonary valve is ugly too?
Good question. Most often, when you have severe involvement of the tricuspid valve that's bad enough to necessitate valve replacement, you are likely going to have significant involvement of the pulmonary valve. So upwards of 80% of individuals will have more than moderate involvement of the pulmonary valve when they already have significant involvement of the tricuspid valve. The minority of cases when the pulmonary valve is not looking good or is affected by carcinoid heart disease, and we leave that in, that is typically when the amount of regurgitation, or in cases of narrowing, when the narrowing is really no more than mild to moderate in severity. So we grade these leakage and stenotic or narrow lesions as mild, moderate, severe, and grades in between. So if you're starting to see moderate or worse, certainly more than moderate leak or narrowing, we would certainly advocate for replacing the pulmonary valve at the same time. If the pulmonary valve is mildly regurgitant or leaky, then it would make sense to just replace the tricuspid valve. But in that case, keep an eye on that pulmonary valve and see whether or not the damage to that pulmonary valve is changing over time.
Yes, thank you for that. This is another excellent question. How often can heart valves be replaced? For example, this person said they had their pulmonic and tricuspid valve replaced via open heart surgery 2 years ago. The pulmonic was replaced again via TAV 3 years later. Both are damaged again. So is a third valve replacement possible?
The definitive answer depends upon how big the original surgical valve was. And the analogy I'd like to give is one of a Russian doll, right? So you have an original surgical valve that was placed, and the subsequent transcatheter valves that are placed have to be placed inside that frame of the existing surgical valve. And so then if you're doing a second transcatheter procedure, you're placing it inside the frame of a transcatheter valve that is slightly smaller than the original surgical valve in most cases. And so as you do more and more and more transcatheter valve and valve replacements, you run out of space inside the region of the valve. Just like if you're fitting multiple dolls one inside the other, they have to, by definition, be smaller than the original size. Otherwise, they're not going to fit inside the original Russian doll. So eventually, the concern is that one might run out of space. And for that reason, it's always prudent, especially if you're a younger individual, to get, or really, regardless of your age, to get the biggest size surgical valve that can be safely fitted, so as to enable future transcatheter valves to be done more than once if necessary, so that you don't run out of space with future replacement procedures.
Thank you. That's a helpful tip there. So following tricuspid and pulmonic valve replacement via open heart surgery, will carcinoid heart disease remain a threat for life? This person noted that their EF is decreased in IVC, now dilated 3 months post-surgery.
So these findings that are described with the EF and the IVC are indicators of congestive heart failure, or I should say sort of weakening of the heart muscle. Now, this can certainly happen after a double valve replacement in somebody who had a severe amount of leakage to begin with, and in some cases can be temporary, in other cases might last in the long term as well. When it comes to the direct threat of carcinoid involvement, like I said earlier, there is only a minority of patients, less than 2% of patients in large surgical series after a surgical prosthetic valve replacement, wherein the surgical valves fail because of carcinoid involvement. So the incidence of that is around about 2% over a 6-year time frame after valve replacement. So the likelihood of that is pretty small. Of course, again, if you have reasons to have left-sided heart involvement, then yes, carcinoid heart disease of your remaining valves can potentially be a concern if you're part of that 10% group that we've discussed previously. I think the bigger issue is monitoring the valves that have already been replaced, and certainly monitoring indices like the ejection fraction and other metrics of the heart function, and making sure that that continues to improve. And if it's not improving, to give medications for the heart that might make it get stronger over time.
And perhaps this is somewhat related. Following a tricuspid valve replacement, there's ventricular events increasing. Will adding more heart medications add to low blood pressure and low heart rate concerns?
By ventricular events, I'm assuming that we're talking about abnormal rhythms that arise from the bottom chambers of the heart or the ventricles. So if you're having ventricular arrhythmias, that can be a potentially serious condition that will necessitate medications for the heart. Some of them can indeed lower blood pressure and lower heart rate. If this is causing problems, and causing the blood pressure and heart rate to get too low, it's important to have a conversation with your cardiologist so that additional medications, some of which might not lower blood pressure and heart rate to that extent, might need to be considered.
Okay, thank you. And how can you address valve replacements when the leaflets are badly damaged or not available?
So when we're sending patients for valve replacements, the idea of these leaflets being excised, right? So when it comes to a surgical valve replacement, the idea is that you go and take out the damaged valve before putting in a new valve. And so regardless of how many leaflets are available or clearly visible, typically the leaflets will be visible, but they'll be very short and retracted. In that case, it doesn't really change the overall surgery, because you would just have to excise or cut out those remaining leaflets and put in a new valve. Sometimes when it comes to transcatheter valve replacement, that's really when the anatomy and the shape of the existing leaflets and the amount of damage, those actually play a much bigger role in a transcatheter procedure, because there are anatomic considerations with respect to how you're going to fit in a new valve without excising the leaflets. So in a transcatheter valve replacement, like I mentioned, you're actually not the term valve replacement is a bit of a misnomer. It's more of a valve implantation, because we're actually not cutting out the existing valve leaflets. We're implanting a new valve within the existing frame of the native valve. And so if the native valve leaflets are damaged, it might pose certain technical challenges when it comes to implanting that prosthetic heart valve. And so this is why we have our heart team meetings and review imaging in detail to make sure that anatomically these valve replacements are doable.
Great, thank
Percutaneously
you.
or through the transcatheter approach.
The team meetings are helpful. On a practical note, in your presentation, you stated that you're at higher risk for surgery if you're an older age. What age would that be?
So that's a good question, and these are really data that are born out of a large series that have looked at age as a numerical factor of determining adverse outcome, and they found that with increasing age, there is an increasing hazard. There is no particular age cutoff beyond which we would say that someone is at a high risk or at a prohibitive risk necessarily as a single number. So there are many other factors that factor into your overall surgical risk, age just really being one of them. So for instance, if you're 85 years of age, your surgical risk is certainly going to be much higher than if you were at 65 years of age. But if you're at 65 and having severe heart failure with abnormal kidney function, and you've lost a lot of muscle mass and body weight, you might be a worse surgical candidate than a much healthier 75-year-old with a completely normal heart squeezing function with minimal symptoms of heart failure and normal kidneys, who is, say, biking 20 miles a day. So age does play into it, but there is no hard and fast cutoff, and it is not the only metric that we use to determine surgical risk.
Yeah,
But that's
it
a good question.
depends. Yeah, it is a good question. So we'll take this last question, and this is a
Yes.
good question. How does someone find a cardiologist knowledgeable in carcinoid heart
Yeah.
disease? And specifically, someone asked about how can they call your team for second opinions if their cardiologist thought they were inoperable and advise a second opinion.
Yeah, the first question is very pertinent with respect to finding a cardiologist knowledgeable in carcinoid heart disease. I think the easiest way to do this is, of course, through forums like the Neuroendocrine Cancer Foundation, where you have a network of providers and you're able to link patients with providers, which is obviously incredibly helpful. I think a valuable resource can be your oncologist. So if you have a specialist who is taking care of your carcinoid tumors and your neuroendocrine cancer, that individual might have partnerships with cardiologists who over time have gained experience in seeing their patients and therefore in taking care of individuals with carcinoid heart disease. So that's certainly an invaluable resource. So certainly ask your oncologist. In addition to these two, with respect to second opinions, you can certainly reach us if you just Google any of our names, you can find or look us up on the Cedars-Sinai website. You can certainly locate us and our office number. So you can certainly reach us for any sort of second opinions. And I would agree, and I certainly encourage some of our patients to get second opinions, should they choose. It's important that you're comfortable with your plan of care. And if that means either reaffirming what your original cardiologist or your provider has recommended for you, or seeking a different alternative treatment plan, and if that's what it takes to have a sense of comfort, then so be it, and you should seek it out actively. And I certainly encourage that.
It's important to be comfortable. Well, we really appreciate you sharing your expertise, and I want to see if you have any closing comments before I send it back to the studio.
Well, no, I just want to thank you all for the opportunity to be here. And carcinoid heart disease is an increasingly recognized problem in our patients with carcinoid tumors. And I think the emphasis really is more on screening and detecting carcinoid heart disease early so that we are able to intervene in time. I think it's a very exciting time for our patients who are suffering from this condition and who are faced with this condition, because now more than ever in 2025, we have a wider and wider variety of treatment options, which I think is exciting for us providers in terms of what we are able to offer. And I again congratulate you for all the work that you have put in bringing awareness to this condition. And I'm again grateful for the opportunity to be here.
And we're grateful for you. As you know from our discussions, this is something that's a little bit near and dear to our hearts, as we've seen people in our community suffer from this, and we know how alone people feel. And we thank you for helping people feel a little less alone and giving them hope by knowing that there are options. So thank you for your dedication, and we really appreciate you. And I'll send it back to Heather in the studio now.
Thank you again, Dr. Venkatesh, for your enlightening and thorough presentation and for answering so many questions on carcinoid heart disease and how it can effectively be treated. We appreciate our supporters: Novartis, Tercera, Ipsen, Exelixis, Curium, Crinetics, ITM, Boehringer Ingelheim, and Inner Science Institute. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at ncf.net/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. If you register for today's webinar, you may receive a survey via email. We would greatly appreciate you completing the survey, as it helps us improve our content and with fundraising efforts. Again, follow us on social media to stay up to date on our upcoming events. Our new handle is @NCFCancer. And now back to Lisa.
Thank you, Heather. The Neuroendocrine Cancer Foundation is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, ncf.net. We offer a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. And thanks again for joining us for today's educational event. Goodbye, and see you at our next event.